Hello, everyone. Welcome to the webinar HER2 Positive Breast Cancer Deep Dive into the Science Behind the Treatment. I'm Victoria Goldberg, a senior producer of the Our MBC Live podcast and a longtime Share Helpline volunteer and MBC support group facilitator. Before the presentation begins, I'd like to tell you a little bit about Share. Share is a national nonprofit that supports, educates, and empowers anyone who has been diagnosed with women's cancers and provides outreach to the general public about signs and symptoms, because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information, please visit our website at sharecancersupport.org. All participants will be muted during the presentation. When Dr. Schiff finishes presenting, we will begin the Q&A discussion. You're welcome to submit questions during the presentation through the Q&A section at the bottom of your screen. When asking questions, remember that Dr. Schiff is unable to give you specific medical advice, so please keep your questions general in nature. This webinar is being recorded and will be available on the Share website soon. Now, I would like to introduce our speaker and a woman I greatly admire, Dr. Rachel Schiff. She has asked me to shorten her bio, but I refuse to do that because I want you to hear what a great person she is. Dr. Schiff is a professor at the Lester and Sue Smith Breast Cancer and the Departments of Medicine and Molecular and Cellular Biology in Baylor College of Medicine. She is an internationally recognized expert in breast cancer translational research with extensive experience in preclinical, therapeutic, and resistant models for various targeted therapies. Dr. Schiff received her PhD from the Hebrew University Hadassah Medical School in Jerusalem and completed her postdoctoral fellowship at the University of Texas Health Science Center, San Antonio, Texas. The major objectives of Dr. Schiff's research lab are to explore the key oncogenetic signaling networks, develop biomarkers to design tailored targeted therapies, and identify the mechanisms responsible for resistance against targeted treatments and metastasis, particularly in estrogen receptor positive and HER2 positive breast cancers. Major research themes include the crosstalk between the ER signaling network and growth factor and cellular kinase pathways. So I would love to welcome Dr. Schiff to share. Here is Dr. Schiff.
Hi, everyone. Can you hear me and see my slides?
Yes, we can.
Thank you. So hello again to everyone. I would like to start by thanking the organizers and leaders of SHARE, as well as the SHARE community, for the opportunity to discuss today with you the topic of HER2 breast cancer, and we will dive, as time will allow us, as deep as possible into the science behind the treatment. And I will try to tell that as a story, the story of HER2, and emphasize the importance in the clinical implications of basic and translational research. These are my disclosures. And the objective of what I would like to do today is to provide a historic and, if you will, a chronological perspective, highlighting the success and the challenges in the development and implementation of a multimodular cancer therapeutic scheme for patients with HER2-positive breast cancer. And I will start my discussion with a brief introduction for clinical breast cancer subtypes and the treatment evolution. And then I will focus on the HER2 pathway, understand the pathway, and most importantly, different targeted therapies. And in the end, as time will permit, I will talk a little bit about current challenges and future directions. So starting with a brief introduction, first, HER2, what is it? It's 15 to 20% of people with breast cancer are having what we so-called HER2 positive breast cancer. And we'll try to understand what does it mean. Clinically, while the breast cancer is a highly heterogeneous disease, we think about major three subtypes clinically. The estrogen receptor positive, which consists about 75% of all breast cancers. These tumors express the estrogen receptor protein, and they are treated by hormonal or endocrine therapy to actually block this pathway of the estrogen receptor. The second subtype, which we'll focus on today, is the HER2 positive breast cancer, which, as we just mentioned, consists about 15 to 20% of all breast cancers. Half of those, important to know, are also estrogen receptor positive, and we will come back to that later. And these tumors overexpress the HER2 protein via gene amplification of the genes that encodes for this protein. And finally, as you all know, we have a triple negative breast cancer, and the third clinical subtype. This is a horrible name for a lack of a better term. You say what they are not. They are triple negative for the estrogen receptor, progesterone receptor, and HER2. Up to a few years ago, all that we could offer these patients or patients with triple negative breast cancer is chemotherapy, but luckily recently, there is some advancements with antibody-drug conjugates as well as immunocheckpoints inhibitors, or also known as the immunotherapies. So focusing on HER2 will be the main focus. I just want to briefly look into the evolution of breast cancer diagnosis and treatment. And before the 70s, the strategy was similar treatment for all patients, or in other words, the concept of one size fits all. We know that doesn't work. Every patient went through radical mastectomy, and the outcome was pretty poor, with 50% risk of recurrences and deaths. In the beginning of the 70s, in 1971, President Nixon signed into law the National Cancer Act. And what that means is declaring war on cancer. And yesterday, we heard that it's going to be redeclared. We heard that from the current president. And what that means is money and resources for research. And that changed the outcome and the course of cancer for so many patients. And we will focus on the patients with breast cancer. So if one looks from then till where we are today, so many important concepts were found. The understanding of the estrogen and the progesterone receptors, endocrine therapies, the concept that breast cancer is very early, in many cases, systemic disease, and we need to give adjuvant therapy to get rid of, if you will, the micrometastases that we cannot detect. Concepts of new and less aggressive surgeries, such as lumpectomy. HER2, which we will focus on today, started in the mid-80s and really booming later on, as we will see. New concept of endocrine therapies, such as aromatase inhibitors. Concepts of prevention, understanding hereditary breast cancer with the identification of BRCA1 and BRCA2. And we can go on and on to where we are today, that we look into the genomics of the entire tumor, new drugs such as the CDK4/6 inhibitors for, as of today, for ER-positive breast cancer, but we are starting to see its use also for HER2-positive breast cancer. And in the era of personalized medicine, or I like to think about it, the precision oncology, we do understand very well that not all breast cancer are alike. And we need to understand and tailor targeted therapy for each patient. And a lot of that will be discussed today in the context of HER2-positive breast cancer. And outcome is much better. We are now talking about a significant reduced risk of recurrences and deaths of about 25%. This is not good enough. Mortality went down, but we need to do much better. And as time will permit, I'll talk towards the end of my discussion today about some other future directions. So the ER story started around early 70s, maybe mid 70s. Close to the 90s is the story of HER2, and later on, and we just started this story, is of about triple negative. And we will focus today on the HER2 story. So let's move into the pathway itself and start to understand what are we talking about. So what is HER2 and the pathway? HER2 is what we call an oncogene, a cancer-causing gene. And most of these oncogenes are normal genes that when they are mutated or overexpressed or amplified, they become oncogenic and they can drive cancer growth and metastasis. HER2 specifically is gene amplified, as we mentioned, in 15 to 20% of tumors. This is what we call classic HER2 positive tumors or clinically HER2 positive tumors. HER2 in these gene amplified tumors is overexpressed, shown here as OE, and that's what drives an aggressive phenotype. These tumors tend to be more resistant to some chemotherapies. They metastasize more to the brain, which is much harder to treat. And in a way, their outcome is pretty poor. That has changed now that we have such great different strategies to block the HER2 pathway. And finally, it's important to understand that the pathway activation of HER2 requires not only HER2, but other members of the family of HER2. So where did we start? We start in the mid of the 1985 when for the first time, the genes that encodes for the HER2 protein, RBB2, was cloned. And once you clone a gene, now everybody can do that in very short time in the lab. That was very new back then. You have now tools to actually overexpress it or knock it down and start to ask functional studies. What does it mean? Very soon after that, it had been shown that there are different breast cancer cell lines that have gene amplification for HER2. And importantly, in 1987, the collaboration between Dennis Lehman and Bill McGuire showed that tumors that overexpress HER2 are actually associated with aggressive breast cancer, which for the first time, altogether from preclinical to clinical data, suggested that that's a new target. This is what we call the identification of a target, or if you will, an enemy in the concept of treatment therapy, and we had to start looking for treatments. And before I can go into treatments, I would like to talk a little bit about the pathway itself. So here we see the HER2 pathway and how it activates. And you can already see that the HER2 is part of the HER family or the HER pathway, which is a complex and redundant pathway. And what it means is that we don't have only HER2. We have four members, HER1 or EGFR, HER2, HER3, and HER4. These are all tyrosine kinase receptors. And the pathway can activate it and activate HER2 upon binding of their own ligands. There are multiple ligands, which leads to homo and heterodimerization via changes in the conformation of these receptors upon binding of the ligand. And then the kinase is activated and start a cascade of phosphorylation. Kinase does phosphorylation, and with a cascade of phosphorylation, you activate downstream signaling such as the PRC kinase AKT, the RAS-MET kinase, and others to eventually phosphorylate transcription factors in the nucleus that will activate gene and protein expressions important for tumor growth, survival, and metastasis. So I will run this slide one more time to show you how the change of the conformation by the ligands can activate this pathway. HER2 doesn't have a ligand. It sits in the membrane in an open conformation. And because of that, when it's overexpressed, such in HER2 positive breast cancer, now we can get dimers of HER2 even without ligands. And this is part of the essence of how you activate HER2 in HER2 positive breast cancer. So going back to our timeline, now that we knew we had to look for a treatment, what had been done early at Genentech is getting HER2 targeted antibodies. You take the protein HER2, you inject it to mice, you get antibodies. And in preclinical settings, such as breast cancer cell lines, or even in tumors that were grown in mice, one could show that these antibodies can neutralize or stop signaling from HER2 and the growth and metastasize of the metastatic process of tumors, model tumors that overexpress HER2. Next, in Genentech, they humanized the antibodies. So now we can use these mouse antibodies in patients without rejection. And the question was, what's next? And next door to that, luckily, was Damon Slayman in UCLA. And he and many other oncologists back then already recognized that they have patients with HER2, and these patients with HER2, certainly in the metastatic setting, were dying. There was nothing effective to offer them. And when this drug became available, it was like probably a magic bullet. It really changed the course for even patients in already a bad, if you will, conditions. So the next step was, okay, let's just make a lot of that and start clinical trials. But we need to understand that Genentech back then was a small company, not the huge pharma which is today. And there was a discussion and kind of a refusion in the beginning from the common company to commit, and luckily, between the pressure from Slayman and patients, eventually enough drug was made and with a commitment to go and do large clinical trials between 92 to 98, which overall proved the efficacy and safety of trastuzumab plus chemotherapy for breast cancer with metastatic or in the metastatic setting. And indeed, in 1998, both trastuzumab was approved for metastatic breast cancer, and trastuzumab, that's the name I should call what you may know as Herceptin, and it was approved together with a test. And that's very important. And that's the HER2 test to find these patients that will benefit from adding trastuzumab to chemotherapy. And you can see that by immunohistochemistry, this black-brown shows us actually the protein that is expressed in all these cancer cells. You can see some normal cells in between that don't have overexpression, or you can see it at the gene level, that these pink bulbs and points or dots, and you can see that they are very strong. This is amplification with a lot of copies of the HER2 gene. And it's so important because if we will give this trastuzumab as a therapy for all breast cancer, and it's really overexpressed and amplified in only 15%, we won't get the signals that will let us continue. So as we move on with targeted therapy or sub-targeted therapy, we always need to understand that associated biomarkers are very critical. The next question was, can we take trastuzumab to the curable, the early disease? And there were massive trials for that, and it was indeed approved based on few of these trials. I'm showing you a combined analysis of 2 of these large clinical trials in the early setting, which have shown that the addition of Herceptin or trastuzumab to chemotherapy led to a reduce in 50% in annual recurrences, which was significant. These data were presented in ASCO 2005, and the president back then, Joe Sledge, said, "Biology has spoken and we should listen." And I think that's a very powerful statement that we should all remember, that we need to listen to the biology of the tumor to know how to treat it well. So how trastuzumab works? As we said already, that's an antibody. It's a monoclonal antibody that binds to the extracellular domain of HER2, and it mostly inhibits signalings that are coming from the dimers of HER2, somewhat less effective other dimers with HER2 or heterodimers with HER1 or HER3. It also has an activity that's shown here as ADCC or antibody-dependent cellular cytotoxicity. And that comes from actually every antibody that binds to a cell, it's already flagged, if you will, the cell for the immune system to come and recognize this cell as a pathogenic cell and kill it. So trastuzumab and other monoclonal antibodies have this effect, and that actually leads to their activity, which one should think about it as an immunomodulator. We didn't understand early on that this is actually part of the activity of trastuzumab, and maybe the important part of trastuzumab, it's coming from its immunomodulation of therapy activity. And what is important that between blocking at least partly the HER2 pathway plus this ADCC activity, it induces cell death. And as we just mentioned, it reduces recurrences in patients by 50% annually in the early setting, and 30% of metastatic breast cancer can benefit even without chemotherapy from this drug. And importantly, it did increase survival rates. However, you can tell that it does well for 50% of cases in the early setting and even less in the metastatic setting. And the question is why? And as you can see here now, maybe we can appreciate well this redundant behavior of the complex. The redundancy can lead into other signaling beyond the HER2, which are highly effectively inhibited by trastuzumab. signaling which are coming with dimers between HER1 and HER2, HER2 and HER3, even HER3 and HER1 are not less important to activate the downstream pathways and eventually leads to tumor growth. And that led for the concept of dual HER2 therapy that one may need to add a second drug to trastuzumab in order to better block the entire, what we call the receptor layer, the entire signaling which are coming from the HER family of receptors. And pertuzumab, not maybe chronologically, but was the second drug that was approved with trastuzumab. Trastuzumab is probably yet the backbone for all therapies that when we first start with. And together, as you know now, it's already have been shown that these two drugs work better both for the metastatic as well as in the early setting, and they are approved accordingly. There is another type or class, if you will, of inhibitors for the HER family, and these are small molecules, tyrosine kinase inhibitors. What these molecules do is they can directly bind to the kinases of these receptors. By the way, HER3 doesn't have an active kinase. It's still highly important in hetero and homodimerized with other receptors. And once you block the kinases of these receptors, they cannot initiate this phosphorylation cascade to eventually push on for gene transcription and other activities that will lead to tumor growth, survival, and metastasis. Now, these are also small molecules. So by definition, they have better access to some tissues, such as, for example, brain, where molecules need to cross the blood-brain barrier, and large molecules such as antibodies, trastuzumab and pertuzumab are not good in doing so. Small molecules are much better. And again, by different combination of trastuzumab with other antibodies or small molecules, one can better inhibit the entire receptor layer signaling and downstream signaling. There are other drugs which are now available for HER2 positive breast cancers. And those are, if you will, a new generation of antibodies. And we call them antibody-drug conjugates, where one actually combine the anti-HER2 activity of trastuzumab, as shown here, with the cytotoxicity of specific chemo agents that you conjugate to these antibodies. And I'll show you in a second how does it look at the level of the molecule itself. And finally, we have now even more sophisticated antibodies, such as margetuximab, that have just been approved towards the end of 2020, where it's the same trastuzumab antibody, but now the Fc part of the antibody, which is the one that engages the immune system, had been optimized to get even a stronger anti-immune activity against these cells beyond just inhibition of HER2 signaling. So now that we have complete blockade in the presence of different combinations, why still we see some resistance and how tumors can evade this effective HER2 inhibition? And one mechanism, before I'm getting into that, I just want to briefly say and show you two slides, I forgot about it, of antibody-drug conjugates. So what you see here is the TDM1, which is trastuzumab, that it's now linked via specific linkers to 3 molecules of potent chemotherapy. This is a chemotherapy by the name DM1, which is a potent tubulin destabilizer. Here is actually trastuzumab deruxtecan, or TDXD, that I'm sure everyone is now hearing. In this case, this is again trastuzumab, but the ratio of drug to antibody is significantly higher, 8 molecules of the drug per 1 antibody molecule. The drug itself, its topoisomerase 1 inhibitor, and this is a very high potency drug, which importantly with membrane permeability. So what it can do, it can get into one cell, kill the cell, leave that cell, go to another cell that may not have HER2 high expression, or maybe doesn't have any HER2, but because it's a neighbor cell and it can go through the membrane of the neighbor cell, it can now also kill the other cell. And what that leads is, this is what we call bystander killing effect. So now we have a tool that we may be able to use even for tumors that maybe not all the cells have high HER2 expression. So going back to our story, What I wanted to say is that what we have done between 98 and maybe 2006, all the way to where we are today, we have done a lot of preclinical, translational work, and eventually clinical trials that led to the approval of every one of the drugs that we have just mentioned: lapatinib, tucatinib, neratinib, the small molecules, the new antibody margetuximab, the two antibody-drug conjugates, TDM1 and trastuzumab deruxtecan. Mostly in the beginning, in the metastatic setting, the lines can change with time, and eventually also in the early disease, and not less important, with different combinations. So I think what one can think of, at least this is the way that I think about the story of HER2, is about the good, the bad, and the hope. It's a bad prognostic marker. It leads to aggressive tumors. The good part is that it's a good predictive markers because we have good therapy. And if you are HER2 positive, you can get very good therapy that you may not benefit if you are HER2 negative. And I think the hope is that you can tell that we are doing better and better here. However, it's still, I believe, an unfinished story. And the reason is that as we went through all these time courses that we just discussed, we gained more knowledge to understand the disease, more treatment options to treat patients. It certainly leads to increased patient outcome improvement. Mortality went down, but we still have key challenges. And just to mention two key ones are, first, the toxicity. And the toxicity that one can think of from all these drugs, it's both clinical toxicity. You do know that some patients cannot even stay on these drugs, certainly not when they are combined with another drug or with chemotherapy. And there is also, if you will, financial toxicity, which is not less important. It's not available to all patients. And even from a healthcare strategy, it's hard to bear the cost. And I think we heard about that yesterday night too. The other challenge is that with all these great drugs, we still see recurrences, especially in the metastatic disease. And the question is why, and can we do better? So with that, I would like to briefly talk now about some challenges that will be related to how to reduce toxicity or de-escalated strategies of treatment, as well as on resistance. So we will start with trying to understand the concept of de-escalation of treatment strategies. For years, through all these time that we developed preclinical and clinical strategies to develop, to treat HER2 positive breast cancer, the strategy was to add more and more HER2 targeted therapy to chemotherapy. And that led to such high, if you will, toxicity for patients. And now we are in the times that we are looking with clinical trials and somehow finally even moving to practice, that we are trying to look into treatment de-escalations. Some patients may benefit from less chemo or less aggressive chemo. Some patients may not need any chemo as long as you can effectively block the HER2 at the level of the entire receptor layer, if you will. So I'll show you how we got into that. And as we talked before, you can tell that when we do the right combination of different HER2 therapies, we can get complete tumor inhibition. And even when HER2 remains inhibited, in some cases, tumor can regrow. And part of that can be via activation of other escape pathways that they provide now the alternative signaling, even when HER2 remains inhibited. And a key one of those is the estrogen receptor. And importantly, there is so much crosstalk, intimate crosstalk between the HER2 and the estrogen receptor ER pathways that I won't have to discuss today. But when one blocks HER2, ER comes back. When one blocks ER, HER2 signaling, HER1, HER2 is coming up. So you can understand already that when you effectively block HER2, estrogen receptor activity and sometimes even expression can go up or even switch from ER negative to ER positive. And if you don't block this pathway will give you the survival signaling. So what can you do for these patients? You need to combine potent HER2 therapy with endocrine therapy to also block the estrogen receptor pathway. And we have shown indeed using multiple preclinical models that dual HER2 blockade with different combination of drugs against HER2 plus endocrine therapy if tumors were ER positive resulted in complete tumor eradication. And briefly, I'm showing you one model here, which is a HER2 positive, ER positive model of cells that breast cancer cells that we are growing in mice, and we look for the size of the tumor over time. And you can see that these are HER2 positive, ER positive. These tumors need estrogen to grow. If you give them endocrine therapy in the form of estrogen deprivation, such as aromatase inhibitor, they will shrink for a while, but very soon will resume growth and become resistant. If you keep the endocrine therapy, but you give them one drug at a time to block HER2, apatinib or trastuzumab, they do very well. They regress, but it's short-lived and they come back. And only when you combine endocrine therapy along with a dual HER2 therapy, you can start eradicating aggressive models. And if you do the same combination in the presence of estrogen, you see only a short time of inhibition and tumors come back. So with these data across multiple models, what we hypothesize that maybe there are some patients with tumors that are so addicted to HER2 that they may not need chemotherapy. And we felt that that's justified additional clinical investigation. And I just want to say that when we started these concepts, nobody wanted to hear about it. People said, no, just give patients more and more therapy. They will be happy as long as you block their tumors. But that's not true. These treatments are coming with a lot of cost. And as I said, it's clinical toxicity and further. So the way that we approach the de-escalation strategy with trying to actually spare patients from chemotherapy is to use the neoadjuvant trial setting. And what you do there is you keep the primary tumor within the breast and you do a pre-surgery treatment for 12 to 24 weeks in our case, in between the different trials that we did. And in the end, you do surgery, and then patients are moving into standard of care therapy. And in the end of these 3 to 6 months, you can either the tumor can completely disappear, and that's what you call pathological complete response, that the pathologist under the microscope will see any evidence for invasive disease in the breast post the treatment. And this is a marker which is, if you will, associated with very good long-term outcome. Or in other cases, there is a residual disease. And if one takes this residual disease, which is coming out through surgery, and actually look molecularly to understand what happens here, one can actually start recognize the given mechanism of resistance for a subpopulation of these cells, that probably this is what you will need to target next to effectively treat these specific treatments. So what we have done is we did a 3 consecutive phase 2 neoadjuvant trials of dual HER2 therapy without chemotherapy, which were done by our group as well as with our collaborator in Spain. In all cases, the treatment was lapatinib plus trastuzumab. Back then, that was the only available and approved combination. And if tumor were ER positive, we also added endocrine therapy. And we had a biopsy at baseline, biopsy in the middle to just understand what happens. And then all patients went to surgery. And we asked, what is the outcome of these 3 to 6 months of treatments? And what we found that there was if you will, a clinical significance rate of PAS-CR of 25 to 30%, which in other words suggests that about 1/4 to 1/3 of all HER2 positive breast cancer may benefit from a chemo-sparing strategy, and all what they need is a good combination of biological therapy against HER2. The challenge now is how can we find these 25 to 30% of patients so we will be comfortable to spare them from chemotherapy, and not less important, what is the mechanism of resistance for the rest of the population, almost 70-75% that probably need more. And we give them chemotherapy because we don't know what else to give them. So what we have done is we actually use now the biopsies of these 3 trials, and we took the first trial to get, I'm just trying to give you an idea of how one can use clinical material back in the lab to understand how to go to the next step. So we look into the first trial, which was a small one, to see what's unique for these tumors. We got from that an idea of how to measure this, if you will, HER2 addiction, that we think that if tumors has enough of that, they won't need chemotherapy. We then use the second trial, our trial, to actually is what we call training cohort to go and develop and refine our molecular classifier, which is a multi-parameter strategy to identify these patients with tumors that are highly HER2 addicted. And eventually, once we lock these parameters, we went and validate that independently in the third clinical trial using the cohort of patients from this trial. And with that, we have now a molecular classifier, multi-parameter molecular classifier that can successfully predict pCR rates for HER2 targeted therapy alone with no chemotherapy, comparable to that of chemotherapy plus dual anti-HER2 therapy in unselected patients. And just to briefly show you what are the parameters for that is, I'm not sure what happened here, First, tumors need to be, as shown here, need to have high and homogeneous levels of HER2 gene and protein. No intratumor heterogeneity, and I'll just briefly try to show you what I mean. What you see here is a new assay that on one slide can look both for the protein shown here by orange, as well as the dots, the black dots here are the copy numbers of the HER2 genes. And together you can appreciate that to the left, all cells have high level of amplification of HER2 and high level of protein. On the right, you can see intra-tumor heterogeneity. Some of the cells actually are high HER2, both by protein and gene amplification, but others have less protein or not even gene amplification. And the tumor on the left is the candidate that it's so highly addicted to HER2 that hopefully we can spare them with chemo. On the right, we understand that these patients still need trastuzumab because they need to get rid of the or other HER2 therapy to get rid of the HER2 positive tumors, but they have other tumor cells that may not benefit by taking away chemotherapy. So as long as we don't understand what drives these cells, we will have to give them chemotherapy. The other parameters of our molecular classifiers, it's also the identity or the behavior of these HER2 here, and that was measured by the HER2 intrinsic or enriched subtype. And finally, we show that these tumors need to be wild type for their PI3 kinase pathway. And just for you to know, PI3 kinase sits immediately downstream from HER2. And 30%, 25 to 30% of HER2 positive breast cancer already have a mutation in PI3 kinase. So if you just block effectively HER2, they will be dependent on the downstream signaling. And for these patients, for example, maybe instead of giving them chemotherapy, in the future, we have some new drugs very effective for PI3 kinase mutations. We would be able to use those along with HER2 therapy and spare them from chemotherapy. And with this molecular classifier in our hand, we are hoping by the end of this summer to actually open a prospective trial that for the first time, we will prospectively find the patients that we think will benefit from the sparing of chemo, but from actually chemo sparing strategy. Now we will move briefly into the resistance question. And again, I will just touch on that very, very briefly. So to begin with, I want to say that when we think about mechanism of resistance to anti-HER2 therapy, we need to think about the entire tumor. And the entire tumor is comprised of mainly two, if you will, components. One is the epithelial tumor cells shown here in gray. This is the cell, and in the middle is its nucleus with the receptors, with HER2 receptor. And this is the epithelial HER2 positive breast cancer. But the whole tumor, it's also comprised of the tumor microenvironment. And we now know that the tumor microenvironment has a very important role in sensitivity and resistance to treatments. And the tumor microenvironment itself has two components. The extracellular component, and this is the matrix that makes, if you will, actually the area in the matrix where these cancer cells are embedded in, as well as other cells that we call them the stromal cells that are also coexist with our epithelial cancer cells. And these are immune cells as well as cancer-associated fibroblasts and other cells. The extracellular matrix itself its texture, how rigid it is, can actually change the activity of the receptors and their sensitivity to ligands. And specific components, I'll show you just one, such as integrin beta, are also very important. And we have shown and published, and others are now going the same direction, that when HER2 remains highly inhibited and highly or effectively inhibited in these models, if we have high expression of beta-1 integrin, it will now reactivate the HER2 pathway and downstream signaling, or in other cases, HER2 will remain inhibited and the beta-1 integrin will activate the downstream pathways. And one can come and block it with monoclonal antibody to integrin, which as of today are not available clinically, but I can tell you that this is work in progress. Another part of the extracellular, of the tumor microenvironment are the cellular cells, and some of the tumors don't have enough active, if you will, immune infiltrate or immune cells. And if we want to engage better the immune activity against our tumor cells within a given tumor, one can come now with new immunotherapy strategies, such as, for example, the immunocheckpoint mutations. And there are now clinical trials that some of those are looking promising to inhibit those immunocheckpoints along with HER2 therapy. There are some other strategies, such as new antibodies with bi and tri-specific. So now they don't even have 2 arms, they have 3 arms. They can bind to the HER2 on one arm, and on the other hand, to selective markers on immune cells to even further engage them in helping of getting rid of these epithelial HER2 positive tumor cells. And there are also another direction, which is HER2-directed vaccine, which may help. It's already looks pretty promising and may help, if not in the early setting, then down the road to inhibit and prevent secondary and further down metastases. Now let's briefly, for the last part of the talk, briefly talk about mechanism of resistance, which are intrinsic from the cancer epithelial cells themselves. And those come in major tool flavors. And we already touched a bit about it. In one side, we have sustained HER2 inhibition, and alternative pathway will have to activate now survival signaling to promote growth. On the other case, HER2 signaling is reactivated, and the question is how. So I'll show you briefly how we can look into that in the lab. And what you see here is one model of HER2 positive breast cancer cell line. In that case, it's actually ER negative. These are the naive or the untreated that we call parental cells. And this is just, we measure different levels and activity of proteins. And to make it simple, I'm showing you here HER2, and the thicker and stronger is the color and these black bands that you see, the more expression we have. This is HER2 overexpressing cells, so you have a lot of HER2. If we measure its phosphorylation level, then we can see it's a surrogate marker for its activity. We can also measure HER1 or EGFR and so on. I'm showing you just for simplicity one. And you can see that we have, for a long time, we can inhibit these cells with dual therapy and they cannot grow. Eventually, when they resume growth, they don't have any reactivation of HER2. And now the question is, what are the escape pathways that can mediate survival? And we already discussed the estrogen receptor. That's not the answer here. As you can tell, this is an ER negative, but it's certainly the answer in some other HER2 positive, ER positive models. It can be downstream signaling, such as mutations in PS3 kinase or along the RAS-MEP kinase pathways that can actually deregulate the pathway downstream from HER2. So it doesn't matter that you block just the HER2 and the HER receptor layer. Down from that, there are a lot of metabolic pathways which are also important. Some of them can actually activate the cell cycle signaling. So we now know that if we block either of these metabolic pathways, and I will just tell you one of them that we found in the lab, it's actually blocking the cholesterol synthesis pathway with drugs such as statin, can actually block the growth of these specific models that I'm showing you here. And we are having now a clinical trial testing that in patients. Or you can actually downstream from this pathway, you can add CDK4/6 inhibitors, which can also work to and help to block the estrogen receptor pathway. And all these type of experiments in the lab and now in clinical trial are being looked. The others are cases where, as we now understand that when the tumor become resistant, they reactivate HER2. And in these specific models that I'm showing you here, we found that now the tumor acquired a mutation in HER2 that can now reactivate the pathway, even in the presence of the drugs. It can be lapatinib or others. And there are many other mechanisms to activate these HER2. It can be by other mutations, for example, amplification for HER1, which can then rephosphorylate HER2 even when HER2 itself continue to be blocked, for example, by tucatinib. There is other crosstalks, and finally, even drug accessibility. And that's important to understand because, for example, if we have the dual antibodies of trastuzumab and pertuzumab, we know that for many patients in the metastatic setting, it can do very well from the neck down. However, these antibodies don't penetrate well the blood-brain barrier, and small molecules can be more effective here. So this is a way to, for example, for these patients, overcome resistance with small molecules. So with that, I just want to briefly say, where are we today? And I think that today, both clinical, preclinical and translational research, as well as clinical trials, are focused on a more what we think and should do, tailored treatment. On one hand, we need to think more about de-escalating strategies with less chemo, no chemotherapy. Maybe not everybody needs the dual inhibition upfront, and should we combine different drugs, and what should be the sequence? And finally, there are other ways maybe to think about de-escalation, and this is for the cost. Hopefully down the road, biosimilar will be cheaper, as well as now the available subcutaneous or injected drugs for trastuzumab plus pertuzumab, which hopefully will make the drug to be more available for more patients, those that, for example, cannot get easily into infusion centers. On the other side, we still have the issue of resistance. We need to better identify the causes, and we need to identify it for each patient. We need to have new diagnostic and technologies to find them early. For example, the liquid biopsy strategies that I didn't have time to cover today. We need new models for these resistant scenarios. We still need new drugs and to understand better how to combine them. So with that, I think I showed you hopefully the hope, but that it's still an unfinished story. My last slide is just a summary, and I just want to emphasize very few points. First is that the introduction of these multiple anti-HER2 therapies resulted in outstanding improvement in survival of patients with HER2-positive breast cancer. It's important and we cannot forget it. However, intrinsic and acquired resistance is still common, especially in the advanced setting. And resistance is multifaceted and context specific, and we briefly touched about it. It depends if it's early or late. It depends on the organ, on the type of the treatment, and the overall makeup of the tumor and the host biological characteristics. We briefly talked about few determinants of response and resistance, and I will just end that I think it's unfinished story because we need to better understand the tumor biology and underlying mechanism of resistance, as well as new diagnostic tools for improved treatment strategies and patient stratification for personalized treatments and patient outcome. And with that, I would like to acknowledge briefly the people from my laboratory who participated and contributed to some of the data that I've shown you today. Our collaborators within Baylor, our clinical team, I work very close with Maury Maui and Kent Osborne, that I'm sure some of you heard about and know them maybe. Our advocates and other key core that we are collaborating with, our statistical and bioinformatics and pathology teams, our outside of Baylor collaborators, and maybe finally, not less important, all the patients and their family, and not only for participating in the trials and donating their tissue, but what I believe is so many other aspects that they teach us every day about the disease and how to go further. And with that, I would like to thank you for your attention and would like to go and have some further discussion through the Q&A.
Thank you so much, Dr. Schiff. It was fascinating, absolutely fascinating. And I have a million questions, and I kept looking at the clock, and we only have a few minutes left. So I don't even know what are the most important questions that I want to ask. So maybe let's go back a little bit. And I love your explanation about what HER2 is, but for a lot of us, there is a lot of confusion because it just sounds like an alphabet soup with all of these different words that we hear: the ERBB2, the EGFR, HER2, HER3, HER1. What exactly are they? Could you just go over this again and again?
Okay.
You mentioned
four receptors: HER1, HER2, HER3, and HER4. HER2, we all know. HER1 is also known as EGFR. It's the same molecule. They're all, if you will, brothers and sisters. They look alike, but each one has its own activity, and they all, like family, depend on each other. So they need to either homodimerize or heterodimerize to activate the pathway. The gene that encodes for HER2 is ERBB2. I mentioned it once because I cannot not mention it as a scientist, but the protein is HER2. We want to inhibit the activity of the proteins. We have HER3, it's another member. And HER2 and HER3, when they heterodimerize, are potently activate very aggressive signaling. HER4, we don't know enough about it, so we kind of not talking about it. All what it's important to understand that there is so much redundancy within the pathway. And the main ones that it's probably very important for reasons that I didn't have to discuss today is HER2. And when it's gene amplified or overexpressed, we need to effectively block each signaling and the entire family.
Thank you so much. Thank you. That was helpful. So to sum up, ERBB2 is a gene on the DNA, and it gets translated into a EGFR family of
only into HER2. Only onto HER2, one gene, one protein, most of the cases. HER1 or EGFR has a different gene. We have four genes for four different members of the families.
I see. Okay, thank you so much. That explains it to me. All right, then we've been hearing a lot, and I think you kind of mentioned it in passing as well, that there are also now intrinsic molecular subtypes. So how are they used in HER2, and what exactly are they?
Yeah, you can tell I was purposely fast about it because this requires another 1 hour to talk about it. So
yeah,
I need to think about how to say that in easy terms. Think about a lady. You can look at the lady of different ways, right? You can talk to her and understand her personality. You can look at the way that she dressed up, and that will tell you about other part of personality. Or you can look for her accomplishments and say, okay, that's me, that's what she can do. Let's think now about HER2, the same. We can measure how much they have, and we know you need to have a lot to really depend on the pathway, because HER2 is important in so many normal cells, but it's not overexpressed that it's becoming an independent. What is oncogene? It's becoming now the driver. It doesn't listen to anymore to what's happening outside. It has an own signaling to continue to grow and metastasize. This is when you have high HER2. Now, sometimes you have high HER2, but for different reasons, it's not functionally active as the driver. But when it gets now the personality, if you will, of a HER2, which means that it's so dependent on HER2, this is what we call HER2 enriched. How we measure it? We measure it by actually expression of a set of genes, 50 genes that one that will tell you between different subtypes of breast cancer, if you use more the HER2 pathway, or if you use more the estrogen receptor pathway, if you look more like basal, triple negative, if you have high proliferation and less. So these tumors that are actually functionally used, the HER2 pathway along with HER1, with EGFR, this is what you recognize by the HER2 enriched. If you will, this is not how they dressed. They are dressed with a lot of HER2, if you will. They decorated with a lot of HER2, but they also, the personality is HER2. They depend on HER2. And that's what you measure with the HER2 enriched, by the HER2 enriched subtype. It's a set of genes that are activated that tells you that this tumor is more reliable on the HER2 pathway.
Okay, wonderful. Thank you. This was the best explanation I've actually heard, because I've been so confused about this. So I think we only have time for maybe 2 more questions, and I'll try to make sure that I ask you. And I'm one of those people, and there are a lot of people in the HER2 community who actually are now known as triple positive subtype. I guess it's becoming a separate subtype. So we all have a lot of questions about it. In the early setting, it's now become I guess it's the standard of care to have a adjuvant year of trastuzumab. And then those of us who are estrogen receptor positive also get 10 years of endocrine treatments. So I've always wondered, and I'm sure a lot of people ask the same question, why is it enough to have just 1 year of trastuzumab and 10 years of endocrine treatments when there is no crosstalk between estrogen receptor and growth factor receptors?
It's a great question. So, and I think you already mentioned, I think you know a lot about it, because you already said, and it's very true, HER2 positive, ER positive, and HER2 positive, ER negative are 2 different diseases, and probably with different etiology. HER2 probably is the mutation and the amplification happen at different time course within the etiology of the disease. But for ER positive, HER2 positive, the dual or even triple negative positive, and they also have downstream the progesterone receptor. We now deal with 2 independent pathways that we need to block. Now, we also need to understand that not all ER positive, HER2 positive are alike. Some are, for example, tumors that all of the cells have both receptors or triple receptors, and some have a combination of ER positive and HER2 positive tumor cells that are together there. So, and I won't have time to talk a lot about it, but I think what one needs to understand is that you need to effectively block both pathways. Now, we give only 1 year of trastuzumab because there were treatments, trials that have shown that 2 years versus 1 year, 1 year was as effective as 2 years of Herceptin. And there was some subtype analysis that was done by different biomarkers, and it didn't obviously show that the dual or triple positive benefit from the 2 years versus 1. It's still somewhat an open question. Why do we give 10 years of endocrine therapy? We did learn that endocrine therapy you need to use for longer time. We have now data to show that for patients with high risk, and if you are dual resistance, dual positive, you may be already in a higher risk. You want to maintain HER2 inhibition for longer time. I won't have time to talk much more about it. You know, the question is whether we should really go back and check and maybe give the dual therapy after some time again. I think that with time, that we will have now mechanisms to go back via liquid biopsies, which means it can be blood test, it can be hopefully down the road some test of our saliva. We may be able to look for residual coming disease, and you will hit immediately with these therapies again, way before you will see it on imaging or with obvious metastasis. But it's a legitimate question, and I think it's an open question. You do know that ER tumors tend to come back after a long time. These are the late recurrences. And the HER2 positive, ER positive may or may not be very different, though with many of those you do see cure, or at least you see for very long time inhibition of the disease.
Right. Thank you so very much. And again, I'm looking at the clock and it's 4 o'clock and I have to end here. So I think we should consider this as the part 1 of the deep dive, and we should do it one more time. And because there are so many questions still unanswered, and I'm sorry to people who have submitted questions that we may not have answered all of them. I want to thank you, Dr. Schiff, for such an informative program. And to our listeners, please take a moment to fill out the survey at the end of the webinar. The survey will show up in the browser when the webinar ends, and the link will also be in the follow-up email. All surveys are anonymous. This concludes our webinar, and thank you again so very much. And I'll see you on the podcast.
Thank you. Thank you everyone for listening, and I'll be happy. You can always approach me if you have further questions.
Oh, I have so many questions. You should not have said that.
That's okay. I want everyone to hear that.
Thank you so much.
Take care.
Take care. Bye-bye.